Hello, my name is Amy Gabbard and I'm a registered nurse working in a critical care unit of the regional medical facility in my area. In this unit, we utilize therapeutic hypothermia protocols for post-cardiac arrest patients. Statistics show that cardiac arrests are the leading cause of death in America today, affecting over 300,000 people each year with a survival rate on average of less than 10%. Due to the cascade of effects that cardiac arrest exerts on the body, the patients who have a return of spontaneous circulation after cardiac arrest face a number of significant neurological, cardiovascular, and systemic deficits. A therapeutic hypothermia protocol has been developed to minimize the effects of cardiac arrest on the body and improve the survival rates of a patient who remains comatose after suffering a cardiac arrest. Today, I will be discussing the protocol, including methods, therapeutic phases, nursing care, and complications of using therapeutic hypothermia treatment to increase a person's survival after experiencing a cardiac arrest. The regional recommendation for therapeutic hypothermia was made by the International Liaison Committee for Resuscitation in October 2002. This recommendation was an unconscious adult patient with spontaneous circulation after an out-of-hospital cardiac arrest should be cooled to 32 degrees to 34 degrees Celsius for 12 to 24 hours when the initial rhythm is ventricular fibrillation, and such cooling may be also beneficial for other rhythms of in-hospital cardiac arrest. In 2002, the American Heart Association updated these recommendations as part of the American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care, adding that induced therapeutic hypothermia may be considered for comatose adult patients with return of spontaneous circulation after in-hospital cardiac arrest of any initial rhythm and after an out-of-hospital cardiac arrest when the initial rhythm is pulseless electric activity or asystole. Comatose is defined as any patient with return of spontaneous circulation who lack meaningful response to verbal commands, eye-opening, and purposeful movement to painful stimuli. This criteria may include patients who are not truly comatose as rated by the Glasgow Coma Scale, but who have suffered significant neurological damage. The majority of hospital-based protocols have inclusion criteria which include beginning the cooling procedures within 6 hours following cardiac arrest and return of spontaneous circulation, systolic blood pressure greater than 90, and mean arterial pressure greater than 60 with or without using IV fluids or vasopressors. Exclusion criteria is institution dependent. In accordance to most protocols, exclusion for therapeutic hypothermia are starting the cooling procedures greater than 6 hours from the return of spontaneous circulation, temperature less than 30 degrees at the time of return of spontaneous circulation, DNR status, ACLS initiated greater than 15 to 30 minutes post-cardiac arrest, major surgery or neurosurgery within 48 hours or 14 days respectively, age less than 18 years, coagulopathy or uncontrollable active bleeding, and a non-cardiac cause of coma, including overdose, intoxication, seizure, infection, stroke, head trauma, or hypoglycemia. Most protocols defer to the OB/GYN for inclusion/exclusion of pregnant women or do not include pregnant women due to the lack of research regarding the risks/benefits of therapeutic hypothermia on pregnancy. Protocols for cooling patients call for the patient to be cooled to 32 to 34 degrees Celsius within 6 hours of return of spontaneous circulation after cardiac arrest. There are no specific protocols on how to cool a patient, and although there are several methods of non-invasive and invasive cooling procedures available. Invasive procedures may include infusing 30 milliliters per kilogram of cold 4 degrees Celsius isotonic fluid with a pressure bag, which can be started in the field by EMS personnel, cold peritoneal, nasogastric, or rectal lavages. Non-invasive procedures include ice packs to the head, neck, axilla, torso, groin, and thighs, cooling blankets placed anterior and posterior to cover the patient, as well as cold water immersion. The choice of cooling protocols is dependent on the facility. A patient's body temperature may be monitored several ways, including tympanic, esophageal, bladder, rectal, and intravascular via a pulmonary artery catheter. Bladder and rectal temperature probes are not as effective at monitoring core body temperatures as they are affected by the presence or absence of urine and feces. Oral and axillary temperatures are not considered accurate as they are influenced by the cooling procedures. Esophageal probes are accurate if placed on average 45 centimeters from the nose, and pulmonary artery catheters are considered the most accurate. It is recommended that the temperatures be recorded by two different methods of monitoring. There are three phases of hypothermia protocol: the induction, the maintenance, and the rewarming phases. The induction or cooling phase should begin as soon as possible after the return of spontaneous circulation. Cooling may begin in the field by EMS personnel or first responders. The goal is to reach a core temperature of 32 degrees Celsius to 34 degrees Celsius within 4 to 6 hours of the onset of cardiac arrest. The maintenance phase consists of maintaining the goal of 32 to 34 degrees Celsius with little or no fluctuation up to 24 hours after the initiation of cooling. Patient care during these two phases are similar, except that during the cooling phase, the nurse is actively cooling the patient to reach the goal temperature, and during the maintenance phase, the nurse is monitoring the patient to maintain this goal. The patient will be mechanically intubated and receiving adequate sedation. Vital signs, including temperature, blood pressure, heart rate, respirations, and oxygen saturation, as well as the presence of shivering and frostbite, should be monitored every 15 minutes until the goal temperature is reached and achieved, and then maintained per hospital protocol. Shivering is a normal response to hypothermic conditions, which causes an increase in the metabolic rate, oxygen consumption, and carbon dioxide production, and impedes reaching and maintaining the target temperature. Therefore, also, signs of shivering include a drop in oxygen saturation, increase in respiration rate, and facial tensing. Neuromuscular blocking agents such as Nimbex, Versed for sedation, and fentanyl for analgesics should be used, are the preferred medications used to reduce the shivering and other physiological stress responses during all phases of therapeutic hypothermia and to facilitate mechanical ventilation. Initial labs including CBC, BMP, PTT, INR, and arterial blood gases are drawn during the induction phase and every 6 hours during the maintenance phase per hospital protocol. During these phases, complications such as arrhythmias, hypotension, hypovolemia, electrolyte imbalances, and hyperglycemia should be monitored. Hospitals utilize their own protocol as how to replace electrolytes and maintain optimal blood sugar goals, as well as manage volume replacement for hypovolemia and the use of vasopressors to manage hypotension. The patient's skin should be monitored for breakdown at a minimum of every 2 hours. During the rewarming phase, which begins 24 hours after the initiation of the cooling phase, the patient is rewarmed slowly. Rewarming involves the periodic removal of the cooling devices and the use of warming methods such as warming blankets, increasing the room temperature, and heat lamps. The goal is to rewarm the patient slowly at a controlled increase of 0.25 to 0.5 degrees Celsius per hour to reach a goal temperature of 36.1 to 37 degrees Celsius within 6 to 8 hours in order to reduce complications such as rapid changes in electrolyte imbalances, hemodynamic changes, cerebral edema, and seizures. Vital signs, temperature, rhythm fluctuations, and the presence of shivering should be monitored. When the patient reaches the goal temperature when the patient reaches 36.1 degrees Celsius, active rewarming and the neuromuscular blockades should be stopped, as well as sedation weaned. Normal therapy is considered to be reached at 37 degrees Celsius and should be maintained at this temperature. Temperatures greater than 37 degrees Celsius should be considered hyperthermia, which is associated with worse neurological outcomes, and therefore the patient should be treated per facility protocol to maintain the temperature of 37 degrees Celsius. Adverse effects and complications of therapeutic hypothermia arise. These include cardiovascular, hematologic, infections, and fluid shifts. Initially, in response to hypothermia, there's an increase in heart rate and blood pressure, which takes place due to the increase in venous return by vasoconstriction of the skin, which is taking place to prevent heat loss and maintain body temperature. As the cooling progresses, bradycardia is the most common arrhythmia, which may be accompanied by QT prolongation and tachyarrhythmias such as atrial fibrillation and ventricular fibrillation. Profound bradycardia, reoccurring arrhythmias, or hypotension, which cannot be corrected with medical interventions, may call for the discontinuation of hypothermia treatment as per the discretion of the physician. Therapeutic hypothermia may also cause bleeding due to the slowing of coagulation enzymes, impairment of platelet function, and thrombocytopenia. If bleeding occurs, cooling should be stopped, the patient warmed, and possibly treated with blood product transfusions. Imbalances of fluid and electrolytes occur during all three phases of therapeutic hypothermia due to cold diuresis, increased renal flow, cellular acidosis, and fluid shifts. Hypokalemia occurs during hypothermia as potassium moves into the cell, and hyperkalemia occurs during rewarming as potassium moves out of the cell. Phosphorus, magnesium, calcium, and blood sugar levels should all be monitored and managed and replaced per hospital protocol. The risk of infection and sepsis are increased in patients receiving therapeutic hypothermia due to a suppressed cellular and antibody immunity, leukopenia, and impaired neutrophil function. The risk of skin breakdown and developing pressure ulcers is increased due to vasoconstriction of the skin and the use of surface cooling methods. Therefore, precautions to prevent skin breakdown should be taken. Nurses have the responsibility for managing patient care, monitoring patients' response to therapy, and communicating to the patient's family all that is being done for the family member. During the induction phase, the nurse must work to cool the patient to reach the goal temperature and maintain this temperature during the maintenance phase while monitoring patient's vital signs. The continuous electrocardiogram will be used to monitor the patient's heart rate and rhythm for the presence of arrhythmias. The nurse will monitor the patient for the presence of shivering and will check the patient's train of 4 on a peripheral nerve stimulator to ensure adequate levels of paralytics, sedations, and analgesics are being utilized. Blood pressure, mean arterial pressure, and central venous pressure should be maintained through fluid replacement and use of vasopressors per facility protocol. The nurse must manage all medication and fluid intravenous drips. The nurse will monitor the patient for frostbite and skin breakdown every 2 hours and perform necessary skin care, including the use of hydrocolloid dressings on bony prominences and elevating extremities to prevent the development of pressure ulcers. The nurse will monitor the patient's lab values and replace electrolytes and utilize insulin as needed per facility protocol. The nurse must manage any temperature greater than 37 degrees during the rewarming phase. The nurse will communicate to the family the expected outcomes as well as the process of therapeutic hypothermia. This explanation should include the phases of therapeutic hypothermia and the monitoring taking place to ensure a positive outcome and minimize complications. The nurse may need to explain the vital signs and electrocardiogram monitoring as well as the medications used and their purpose to the family members. It is also important for the nurse to explain to the family any complications which may arise over the period in which therapeutic hypothermia is being used. Patients who experience a cardiac arrest with a return of spontaneous circulation can benefit greatly from therapeutic hypothermia to minimize cardiac and neurological injury if cooled to 32 to 34 degrees Celsius for a period of 12 to 24 hours. These patients must be monitored closely to keep temperature within the goal range and manage complications which rise out of the therapy. Therapeutic hypothermia has been proven to decrease mortality and improve neurological outcomes in patients who experience cardiac arrest and is the American Heart Association recommended treatment for any patient who experiences a cardiac arrest regardless of the presenting rhythm. Thank you and have a good day.